Welcome back, everyone, to a new episode of the NRG Oncology Podcast. Today, it's our pleasure to welcome Dr. Ted Hong, who is Director of Gastrointestinal Radiation Oncology at the Massachusetts General Hospital and Chair of the NRG Oncology Non-Colorectal Gastrointestinal Core Committee. He's built a career advocating for new radiation technologies for gastrointestinal cancers and is the National Principal Investigator of NRG-Oncology GI003 for one of the most common kinds of liver cancer. Dr. Hong, to start off, can you talk about what hepatocellular carcinoma is and the worldwide burden of this kind of liver cancer?
Thank you, Dr. Henke, and thank you, Dr. Chen, for the invitation. So this type of liver cancer is a cancer called hepatocellular carcinoma, which is the most common type of liver cancer or primary liver cancer, meaning it starts in the liver. It's not cancer that has spread to the liver from another primary site. This is actually the sixth most common cancer and the fourth leading cause of cancer death worldwide. So it is a huge problem worldwide in terms of cancer burden. Additionally, the incidence of hepatocellular carcinoma really varies by region, and there's some common risk factors that have been identified, like viral hepatitis and alcohol use. So again, a major worldwide cancer problem.
For hepatocellular carcinoma, what exactly is the role of radiation in management? For example, there are options like surgery, transarterial chemoembolization, also known as TACE, where they inject chemotherapy right into the tumor, microwave or radiofrequency ablations, and in certain situations, even radioactive Y90. What is the general approach to hepatocellular carcinoma in oncology, and where does radiation fit into the mix?
So that's a great question. So hepatocellular carcinoma is a very unique type of cancer in that even in the absence of surgical resection options, when the cancer is confined to the liver, we like to think about what we call liver-directed therapies, ways to try to treat the cancer in the liver as opposed to putting somebody on indefinite systemic therapy. Now, of course, we do like to think about surgery or even liver transplantation, but the reality is really the minority of patients who are eligible for that type of operation, meaning that there is a large group of patients in whom we think about all the types of liver-directed therapies that you just mentioned. Where I think about using external beam radiation, the type of radiation that this study is evaluating, is really when the goal of treatment is to try to ablate the tumor, meaning essentially be a surgical substitute in a patient who does not have a surgical option. In this situation, there are particular situations that are particularly amenable to external beam radiation, and this includes when the tumor is in an anatomically difficult area that might be hard to ablate with a percutaneous or a needle-based approach. So this could be in the diaphragm, or it could be near a major blood vessel. Additionally, this type of cancer likes to go into blood vessels, particularly the veins in the liver, and those areas can be very hard to treat for other modalities, and that's really a great situation to think about using radiation therapy. And the other thing is when the tumor is greater than 3 centimeters in size, it's been well established that those are harder to fully treat with these percutaneous ablative approaches, and external beam radiation is an excellent option for those size tumors. The last thing that I'll parenthetically mention is that just in the last month, there has been an important phase 3 randomized trial that was just completed by NRG called NRG-RTOG1112 that confirms that the use of this radiation approach, this stereotactic body radiation therapy, does improve cure rates in patients with unresectable HCC. So based on that data, I would say that radiation is an outstanding option for many patients whose tumors are not amenable to surgery.
So, for those of you who aren't radiation oncologists, protons and photons in Dr. Hong's trial GI003, which is a topic that we'll get into here, might sound like something out of a sci-fi movie, but we'll do our best to bring this back down to planet Earth. A lot of people out there might think of the proton torpedo that Luke Skywalker used to destroy the Death Star, or photon torpedoes used in Star Trek against the Klingons. And I want to just reassure anyone in the audience unfamiliar with medical radiation and the topics we'll address today that our protons and photons are not capable of destroying spaceships or anything like that. Dr. Hong, since this is the first time we're discussing proton therapy on this podcast, what exactly is proton therapy and how does it differ from the typical kind of photon radiation that we often use for cancer?
Proton therapy is a highly specialized form of external radiation. It may be helpful to actually think about what the most commonly used of external radiation is, which is high energy X-rays. So when you think about X-rays, you intuitively know that they go all the way through you or a person or a tumor. And how do you know that? Well, you think about if you break your hand. If you break your hand, you have an X-ray source on one side and a film on the other, and what gets all the way through is what makes the picture. And similarly, when we treat with high energy X-rays, we come in from lots of different angles, and where they all focus in is where they get the highest dose. But there is something called exit dose, meaning these X-rays hit the tumor and then keep going all the way through. And what that leads to is radiation exposure to normal areas that you didn't really need to or intend to hit. Protons, in contrast to X-rays, are charged particles, meaning that they have size and mass. And because of that, we are able to control the depth at which the protons go. So based on the energy or the speed that the protons are emitted, we can control exactly how deeply they go in so that they stop wherever we want them to stop and everything behind the tumor doesn't get radiated. Another way to think about this is it's sort of like a roach motel. They check in, but they don't check out. What this can lead to is a lot of sparing of radiation exposure to normal organs. And in doing so, it can allow for either safer delivery of radiation therapy, fewer side effects, or in some cases, even the opportunity to go to a higher dose of radiation, which might be more effective in killing a tumor. That's why there's so much interest in proton research, and that's why we're interested in studying protons for liver cancer.
So given the advantages you describe with protons, why are we even doing a trial comparing them with photons, say in NRG-GI003? NRG Oncology has done a number of trials comparing protons and photons or X-rays for lung cancer, brain tumors, and hepatocellular carcinoma. Why not just treat everyone with protons given what you've described?
So that is a great question. And in fact, I would say that this is one of the most common questions that I get asked in patients who are looking for proton therapy. There's some pragmatic reasons and there's some technical reasons as to why we don't just routinely offer protons to everybody. One pragmatic reason is that proton facilities are far more expensive than photon facilities. And because of that, the number of proton centers is far fewer than the number of normal X-ray-based radiation centers. So the capacity to treat lots of patients with proton therapy is really not there currently. But there's actually some important technical and biological reasons why we don't know if protons really are better for everybody. So one of the downsides of being a charged particle is that the protons are a lot more sensitive to changes in density than X-rays are. And where would that matter? That could matter when there's a tumor at the top of the liver near the diaphragm, and as somebody breathes, the tumor might be moving in and out of the proton field, and the protons then may be at risk of either being undercovered in some areas in terms of completely treating the tumor, or ranging out into an important structure like the heart. So it's not a guarantee that protons are always going to lead to a better outcome. Additionally, there are some important biological differences between protons and X-rays, particularly at what we call the end of range of protons. There is a growing acknowledgement that there may be a difference in biological activity where those protons slow down and may paradoxically produce potentially greater normal tissue injury in that very small area compared to x-rays. So without really studying this in a randomized trial, we can't just say it looks better on paper, so it must be better for everybody. We really do need to generate the data that protons are, in fact, better than photons if we're going to recommend it as a standard treatment.
So, with all this in mind, for your trial, NRG GI003, comparing protons with standard radiation for hepatocellular carcinoma, what were the major lines of evidence that then led to this trial? And what is the design and what are the major goals of this trial?
There had been a lot of parallel development of radiation techniques with protons and x-rays for hepatocellular carcinoma. And one thing that had emerged pretty early on was that both techniques seemed to be outstanding at controlling hepatocellular carcinoma with very high control rates in the area that got radiated. But as the data accumulated for both protons and x-rays, people started to notice that the risk of the liver not working as well at a 3-month or 6-month time point after the completion of radiation seemed to be more favorable for patients treated with protons as opposed to with x-rays. So a while ago, we evaluated our data at the Massachusetts General Hospital, where we looked at patients who were treated for hepatocellular carcinoma with either protons or x-rays, and we noticed an almost identical tumor control rate, but we also noticed that the risk of having liver function deteriorate over time seemed to be a lot less with proton therapy, and this then correlated with a greater likelihood of patients being alive at 1 and 2 years after the completion of radiation therapy. So based on this, we designed the current trial NRG-GI003 to take patients with unresectable hepatocellular carcinoma, and they're randomized between protons and x-rays given identically in both arms otherwise, other than the modality, with a goal of trying to show that protons lead to more patients being alive at a future time point. In other words, what we call overall survival as the primary endpoint. We did not choose to do a disease control rate because we think the disease control is going to be similar between the protons and the x-rays, but we are very interested in seeing if this more expensive modality does actually cure more patients.
I think just about every trial that NRG Oncology has done with protons has struggled to accrue. We see that enrollment rates, whether it's lung cancer, hepatocellular carcinoma, are usually well below what we would want or anticipate. What has enrollment been like so far for you with this trial, and what are the major obstacles you're seeing? And also, is there any kind of advice you would have for investigators out there who are trying to enroll patients on NRG-GI003?
Thank you for that question, Dr. Chen. So accrual to this study has been steady but slow. And I think that the reason why this study has accrued slowly is primarily because based on what I just told you in terms of what is the rationale for recommending protons, a lot of investigators, a lot of patients have already made up their minds about whether they think protons are useful or not. And for that reason are treating patients with protons or not with protons based on how they feel about the evidence that I just was discussing. My advice and my bias, of course, is that we don't actually have evidence that one modality is any better than the other. And I did give some examples of some reasons why protons may not be better in all clinical situations. So when I meet a patient and talk to them about this study, the way I talk about this is we have two outstanding high-tech forms of radiation. One is with X-ray based SBRT and the other is with proton based SBRT. And the analogy that I give is that there's two major types of smartphones. People can use Android based or people can use Apple based. The Apple phones are more expensive, but the Android and the Apples pretty much do everything that you could possibly want them to do. And no one knows if the additional cost of an iPhone is necessarily justified. So along those lines, I make the same analogy that protons are fancy, they're certainly more expensive, but we don't have any proof that they're actually any better. But if you enroll on the study, either way, you're getting 5 treatments and you're getting a super high-tech form of radiation that has documented track record of having great clinical outcomes. And that's the way I talk to my patients about this study.
I really love that analogy because I think a lot of people can relate to different types of cell phone technology and then also can naturally understand that, Androids and iPhones, like you said, largely do the same thing. Maybe sometimes green versus blue text message wars might ensue. On the whole, pretty darn similar. So obviously, for all the reasons we've discussed, we want NRG-GI003 to be successful and hopefully improve outcomes for patients with hepatocellular carcinoma. But ideally, many of these patients would not come to us in the first place, as many of these hepatocellular cancers might actually be entirely preventable. So in closing, what are some practical things that we all can do to potentially prevent hepatocellular carcinoma in the first place?
So I think that the important things are to recognize what some of the risk features are of developing hepatocellular carcinoma and identifying who needs to be screened. So patients with hepatitis who are at risk for developing hepatocellular carcinoma need to be in screening programs. Additionally, we should be very careful about how we follow patients with cirrhosis as well. The other thing is that there is a growing incidence of patients developing fatty liver due to what we call metabolic syndrome, which really clusters with a lot of other general health problems that are seen in the modern age as they pertain to things like central obesity and other things that can raise the risk of hepatocellular carcinoma. And I think that general health guidelines to improve diet and exercise will also be important to decrease the risk of hepatocellular carcinoma worldwide. But ultimately, I do think education will be really important for this very common and deadly disease to understand if one should be in a screening program for hepatocellular carcinoma.
In this country, historically, we haven't seen hepatitis B as a problem for quite some time. Of course, the hepatitis B vaccine developed largely as a result of Baruch Blumberg, who received the Nobel Prize in Medicine for the basic science that led to the hepatitis B vaccination. As you're probably aware, I think all of us are aware that there is this anti-vaccine movement now. And I'm wondering if you could just speak a little to the power of the hepatitis B vaccine at preventing hepatocellular carcinoma. And this remains a major problem in many places like Asia, where hepatitis B is endemic and causes a lot of hepatocellular carcinoma because of lack of vaccine access.
That's a great point, Dr. Chen. I think that we have had the luxury in the United States of not having hepatitis B be as endemic a problem and cause of healthcare morbidity as other parts of the world. And in large part, that's due to our public health policies that have led to some degree of control of hepatitis B. But hepatitis B is absolutely an important risk factor for developing hepatocellular carcinoma. And interestingly, through a way that doesn't necessarily go through cirrhosis, but rather as a function of DNA integration from the virus into hepatocytes. So, by that measure, it is so important for us to do everything we can to keep the incidence of viral hepatitis B infection as low as possible. The other thing that I find really interesting is that when patients are co-infected with hepatitis B and hepatitis C, there is synergy with those two infections in terms of risk of developing hepatocellular carcinoma. So I would agree with you that I think that hepatitis B vaccinations have been a modern success story in reducing both the risk of what can happen with prolonged hepatitis B, things that can happen with exposure to things like chemotherapy with untreated hepatitis B, but certainly as it pertains to things like the risk of developing hepatocellular carcinoma, I think it is an important public health message for us to remember.
And since you bring it up, hepatitis C, I think the three of us know the risk factors there, but could you elaborate a little bit more on what we can do as a society to reduce the incidence of hepatitis C, which is a clearly linked risk factor for development of hepatocellular carcinoma?
Absolutely. So I think again, screening for hepatitis C, if one has any risk factors for developing hepatitis C is important, and then treatment for hepatitis C. We're so fortunate to live in an era now where during our medical careers, we have seen game-changing medications that can now clear hepatitis C. But hepatitis C was one of the first well-elucidated virally induced cancer pathways and timetables with a 2-decade risk from hepatitis C exposure to infection to developing HCC with a defined rate of HCC risk per year. And that is more cirrhosis related. But absolutely, I think that that's what I was alluding to in terms of what can we do to try to decrease the risk of HCC. I think that patients with a long history of untreated hepatitis C absolutely should be in a screening program so that if there's an HCC that develops, it is caught early at a point where it's still highly curable.
Well, I appreciate all of your insight, Dr. Hong, and I want to just return to, what we were talking about, that his trial, NRG-GI003, is an important trial comparing photon and proton therapy for hepatocellular carcinoma. This is a very important protocol that can help us reduce the side effects related to radiation for liver cancers potentially, and we would be enormously grateful for anything that investigators can do out there to support this trial. Dr. Hong, thanks for joining us, and we want to wish you luck getting GI003 across the finish line.
And thank you, Dr. Chen and Dr. Henke, for the invitation. I think this is a really important study and would be very grateful for any support in answering this very important question. Thank you very much.
The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of the podcast does not necessarily represent that of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.